speaker is Chris Newton. He is Director of our Genomic Services here, also a pediatric general surgeon. But he's going to talk to us about disaster preparedness. He has a long history of military and consulting in Iraq and Afghanistan. So I'm sure he can give us the best information on disaster preparedness. He's done a few disasters himself. And just welcome Dr. Chris Newton.
I think most of you know me. Let's see, there's a good crowd. How many, is this all PACU and OR tech? I'm seeing a few close. So ER, NICU, ICU, oncology. Oh, all right. That's awesome. Thanks for coming. And OR management and OR techs and CPD. And so this is kind of a mix of all sorts of folks. Okay. So, you know, I was asked to talk about disaster management, mass casualty stuff, largely as it pertains to how the pediatrics affects what you do, and how it affects the OR flow and staff, and exactly, you know, what do you do in the midst of disaster stuff. Now, this topic you could spend an entire 2-day conference on. So there are many aspects of of this that you can delve into and get into a lot of details. And there's obviously no way that I'm going to cover the whole thing in 1 hour. So so my apologies in the beginning for all the things that are left unsaid. There's just no way to do this. So I will try my best to focus on big general principles and how it applies, and in some respects, maybe more than giving you detailed information, have some kind of open discussion forum here. So unlike most PowerPoint lectures, please stop, raise your hand, ask questions as things go on. That is kind of the point, and see if we can get information that's really valuable to you. So I'll do a lot of big general principles and maybe a little bit of epidemiology, and I want to get to, after the big general principles, what makes kids in a disaster or a mass casualty different than everything else. How do kids in this whole system affect, not just here, but at the adult hospitals, at San Francisco General and Highland, and what happens with the whole system for pediatrics. And I also want to give you a sense at the end of this of some resources that are out there, and a lot of things that are happening nationally at the state and regionally and within individual hospitals and places that you can go and get more information and stuff. So is there a packet with my slides that hopefully gets sent out? And okay. At the end of this, I'll make sure that if you guys want the slide deck, because there's references in there, there's websites to go track and get more information. Okay, so what do you guys think? Disaster happens. How do kids impact the system? It's okay, you guys. This is the free flow time. For big disasters, so hurricanes, earthquakes. What do you think? Are kids a big part of it?
Yes.
How?
They're small.
They're small.
How they all can be treated if there's a huge disaster. You have one hospital that's available. You got 300 kids.
Before the disaster, you already have limited resources.
Yes. Right.
Well, that's true. That's a problem. And limited expertise. There's a lot of neurosurgeons that won't take care of the 10-year-old, and for good reason. They don't know. Yeah.
It's also the fact that oftentimes where the children would then be treated, their parents would not be. So you have this separation of the children and
Yes.
parents.
So you have a heterogeneous population, right? Kids do not come by themselves typically. And if they do come by themselves, you may even have an even worse problem. All right, so you would think that on any given disaster, that the percentage of kids represents the same percentage as the population. So according to US Census, pediatrics, so under 18, is 24% of the US population. So you would think that if there's a hurricane or earthquake or disaster, about roughly 20 to 25% are going to be kids. When you look at the disasters that have happened over the past 20, 30, 40 years in all parts of the world, Haiti, Iraq, Afghanistan, you can look at all the earthquakes and everything. That's interesting numbers. That's not 25%. And you can also imagine, as you are seeing in the news, there are a lot of incidents that are heavily weighted towards kids. In some respects, kids are a disproportionate amount of what you have to deal with. And in some respects, in things like Haiti, the issue is not the actual building falling down. It's the 72 hours after the building falls down, when the kids' parents are dead and there's no food and there's, infectious issues. And now it's not immediate, but 7 days after the earthquake, all of the pediatric resources in the hospital now account for 50% of the demand, which is what happened in Haiti. So this is just giving some sense of why this is a really challenging topic. So this was, I've unfortunately been in the middle of a few of these. So this was my first week in Missouri in 2008. So there was there's an annual pilgrimage for Muslims that happens, and there was a ton of families and school buses and all sorts of people going to Baghdad and Kirkuk in northern Iraq. And at that time there was suicide bombs, and it was like one of the worst suicide bombs that they'd had. And oddly enough, this didn't show up on any news feed in the US. It was kind of strange. So there was a school bus filled with Muslim kids from Turkey that got bombed. And there was 27 that survived, but were critically ill. And so they needed to transport all the kids to Turkey. And so they stopped off at the US base. And so we were tasked with do the best you can to stabilize them until we can get them on a plane. So this is 27 level 1 criticals all at once. Not staged. They all need the OR. And you got 2 surgeons. Right. That's overwhelming. Okay? And you quickly realize in a hospital that is geared towards adults and is geared towards soldiers, that 27 kids that all need the OR presents a very unique challenge. I tell you this story because we learned a lot from this. The US military learned a lot from this event, realizing, oh my God, we're in Iraq and Afghanistan, and guess what? We are not treating only soldiers. And we are not prepared for this, equipment-wise or experience-wise. And this led to a big push of trying to, help change some things. And led to me, doing a lot of protocol changes, throughout the country in Iraq, in the later years. So, this is a challenge to get over. This is not easy, even when you're good. All right, so that's a unique scenario. I would not expect, things that happen in northern Iraq to be what you guys experience here in the Bay Area. So what do you guys need to plan on? Earthquakes. Yeah.
Fires.
According to Dr. Betts, it's gonna happen. What else?
Fires.
Fires. Yep.
Well, now shootings in schools.
Shootings.
Yeah. Shootings and active shooters, and as the list pointed out, those active shootings can be heavily biased towards younger populations. And yes, that is the scenario of getting 10, 15, 20 kids all at once, and all critically injured. And yeah, you do have to prepare for that. Anything else?
Bus crashes.
Bus crash.
Airplanes.
Airplanes, buses, the Asiana stuff. The other couple things that frequently get talked about in these is infectious disease issues. So the H1N1 surge issues. So it's not a single mass casualty, but overwhelms the system. And there's not backup plans for kids. There's not extra PICUs down the street at the adult hospital, or extra ORs. And the other issue is evacuations. So what happens when this hospital is, for some reason, like the fire in Santa Rosa? Okay, now you've got to evacuate this hospital to where, and to what expertise. So part of the reason I bring this up in the very beginning is, once again, to give you an illustration of how big this topic is. Okay? On each of these, you could spend an entire hour lecturing. Right? And I want you to recognize they are different challenges. They're very different scenarios, and a lot of the things that we preach do not necessarily translate one to the other. So I am not going to talk about evacuations. And I'm not going to get in too much into surge. Wonderful topics, but like I said, there's just not enough time. All right, so let me cover, and hopefully fairly quickly, because a lot of this is anecdotal points, general principles of setting up and preparing for a mass casualty or disaster scenario. And these include stuff for just adults and kids. So when we go into any system and we look at the plan, and we try to decide, this is, we need to make these improvements, these are the few things that we teach and try to look at. So issue number one is, this is not like your standard daily practice. And in your standard daily practice in any hospital, the patient in front of you gets everything. Okay? This is a game of save and help the most people, provided the resources that you have. Okay? Entirely different principle when you begin to think about the details. The curveball of kids is, emotionally, both in our minds and in the minds of their families and their parents, this doesn't apply when it's talking to my kid, even with minor injury. That becomes a very, very difficult statement when you're talking about 5-year-olds. Okay. All right, developing a plan. You need to anticipate the problems, the same game that we were just playing. What's the most likely scenarios? What are the resources that we have? How are we going to deal with it? So you look at your plan and you kind of figure out exactly what this hospital will do. Some of the concerns are, mass casualty and disaster incidents are dynamic situations. It doesn't happen in one time period. It comes in phases. And typically speaking, when there's a disaster, you will have every 4 hours or every 8 hours an entirely new set of patients rolling to your front door. And sometimes phase 2 and phase 3 has more critical patients than phase 1. As patients get in, the entire system, once again, is dynamic. They don't stay in one spot. They flow through the whole system. They start at the front door, they go to the ER, they may go off to clinic to sit there, they go to the OR, they go to the ICU, sometimes they leave. Things change on a minute-by-minute basis. And all of your thinking and all your plans has to revolve around the best care for the most people, depending on your resources, and it revolves around flow. Patients have to be able to move. If they're stuck in one spot, you got a problem. All right? Next, big general principle. If your staff or your hospital are not functioning, then the patients are not going to get anything. So if your staff are at risk, or injured, or exposed to chemicals, or whatever it may be, then the patients get nothing. So you must take care of safety for your own staff and your own family. And that includes communications. Because in a mass situation, every staff member here has family. And that they want to know that their own family's okay. And you got to figure out a way to deal with that. And this is talking about the same thing. This man, by the way, was the former trauma director at Penn, and is one of only 2 docs killed in Iraq. This is when the hospital was bombed. So once again, if the site of your building is not functioning, all of the things we talk about suddenly change. All right. In any given plan, there's different areas that get mapped out on a map. The most important area, usually, is the big triage area. So this is where you'll see pictures on CNN of, they got gurneys lined up, and 50 gurneys. Or cots down on the ground. And this is where they do the initial triage. And they say, this patient's okay, and this patient can wait, and this one's really in trouble, or however they're going to classify it. And it's important to know, from an OR ICU flow standpoint, that is also the place where information is flowing. Remember, patient movement and flow is key here. Down in that triage area is a command center. And there's usually one person down there with a walkie-talkie and a clipboard, knowing, well, I've got an opening in PACU, I've got an opening in ICU, this one there, whatever. Okay? If you're in the PACU and you are full and you're done, you can't take any more, that guy down in triage needs to know that. Because otherwise you're going to get 5 more patients at the next wave. Okay? Knowing how that's set up so that you know who to contact is a big key to the whole system. And if you need to decompress somewhere and send patients to the floor, or you want to hold patients in a clinic, okay, you're not going to call the ICU suite, you're going to call the triage commander. And he's going to tell you, I got 10 beds available for you in ortho clinic, or whatever the answer is. Right? It's a little different system than your daily routine. Okay, next big general principle. And I'm probably going to get in trouble for this. So I'm sorry up front. In a mass casualty situation, in a disaster, state regulatory laws and union rules don't exist. Now, there are those who will disagree with me, and this is why I say I will get in trouble for saying that statement. But trust me, it's true. This means anybody that is capable can do any job. If you're a warm body and we need you in the OR, you know what? We're all human beings. And, if someone comes to you and says, Mary, I need you to come down to the ER and put a finger in the bleeder. Guess what Mary's going to do? She's going to do it because she's Mary. She knows.
I'll have to sit down while I do it so I don't faint.
That's yourself.
And the truth is, when these are really happening, flexibility and creativity become really, really key. And you may have a chaplain sitting in your recovery room looking at the monitor, and you tell me if that pulse goes over 200. And you know what? Does that follow Jacob? No, but you're going to do it. Because that's how you get through this. That's how you survive. And you need to open your mind to the idea of flexibility and cross-training and filling in the holes, whatever the patients need and however they move. And the more you can put that into your expectations and your drills and the plans, the easier this will get. Okay. Questions? Those, like I said, that big general principles here or Highland or San Francisco General, anywhere, that's kind of how you begin to look at this whole process. Questions about that before I begin to get into specifics?
My mind is just spinning of all these thoughts, but just say there was a disaster at 11 o'clock today.
Yes.
Would you immediately just send all the elective cases home? Like that would be the first thing that you would do, like to clear up your space, right? And then do we even have designated triage areas in our plan?
There is.
Okay.
So there is, and I specifically didn't want to get too much into children's plan, but it does exist. And yes, in any given scenario, there is usually half an hour or so, and during that half hour, there is a process of setting up that command center that sets up, the people who are, making decisions, and that is when, yes, they will say nursing supervisor is going to go through the whole hospital, and anyone who can walk and eat is discharged immediately, and all elective cases are canceled. And clear out, ortho clinic. Ortho clinic's canceled because that's now going to be, the minor area. Okay, all of those things happen, and you got about 20 to 30 minutes to set up. And yes, there is a written plan of where the initial triage is going to be and how patients are going to flow. That's written out. I will tell you that for children's, once again, with the opening of the new building, that plan is going to have to change. That new building now affects everything that's written down. And so in about 2 or 3 months, there's going to be an entirely new system for how that would be set up, and more to come. So, so I would expect sometime in the summer, we'll have another, something like this to go over exactly what all those things are. And I do this once every 2 or 3 years with groups talking about the children's plan. Other questions about just big general principles?
We all report to our managers, and they tell us what to do, correct?
Correct. So there is, for children's, there's 2 different reporting systems. Depending on the department you're in, most departments, if you have a place you always go to the ICU, you always go to the OR, there's usually a phone tree. Okay? And so you get called and yes, I want you to come in 4 hours. So not everyone comes in immediately. Okay? They will intentionally stagger the staff because you need to be able to function for 36 to 72 hours nonstop. So the phone tree for most departments is how that happens. For everyone else that doesn't have an automated, phone tree kind of thing, there's what's called a labor pool. So there's a spot that's set up near the command center that if you don't know where you're going, you go and say, I'm Dr. Newton, where do you need me? And they'll say, please go mop, OR 3. So I'll get them mop. And that's how the whole system works. All right? So, excuse me, as was suggested, so this is getting into more of the specifics. So, as it happens, we were just talking about, there's usually a setup period, a 20 to 30 minute setup period. And there is a national standard for how the command centers run and how it sets up. It's called the FEMA NIMS system. And this defines, there's going to be one guy who's in command and one guy who's talking to the media and one guy who's, doing security and things like this. So all these roles are very well defined. So the call comes over that, hey, there's 50 patients coming in, and all those roles instantly get filled. We start emptying out the hospital, we close the clinics, we close all main ORs, and the Connex is out underneath the helipads, get opened up, and they set up all the gurneys and in the circle area, and that's how you got 20 minutes to do it, roughly. All right. Once the triage area starts, patients will roll in, and there is usually, once again, a triage doc who's down there going from bed to bed or cot to cot and assigning levels of severity. So, and once again, this is adult or kids. They will say, this patient can walk, please walk them over to OPC. The primary care docs can see them in clinic, and that moves them out of the way. For triaging kids, this is a simple tool that's used by FEMA and DoD of classifying minimal, delayed, immediate, and expected. Okay? When you begin to do this for kids, it begins a little bit more complicated. And of course, pediatricians have taken this system and stirred it all up and made it very confusing. So to simplify, for kids, they have added this interesting triangle. Okay? And it still gets to, are they not going to survive, or are they minimally injured in all the categories? This triangle, just to summarize, is looking at the kid from across the room, and you're looking at their head, their circulation status, and their breathing. That's it. Do they respond? Are they talking? Are they breathing? Are they blue and cold? And it's a very generalized, gross way of saying kids in trouble or not. Right? And so American Academy of Pediatrics and all the pediatricians involved have advocated this over the last several years and put it into these triage protocols. Right? Once you get divided into a certain category in that initial triage area, sometimes that means you move out of the triage area. So the two easiest categories in terms of the doc figuring out where they're going to go is minimal and expected. So minimal means they're walking and they're doing fine, and they're not going to need much of anything. Expected means they're just not going to survive, and you determine this up front. So once again, the pediatric curveball is putting any child into that expected category is really hard. And it's heartbreaking, and most can't do it. So when it comes to kids, you wind up, kid winds up going in that category because you just can't do it. Okay. We still set up, an area for this, and the idea is any kid that goes into that area is not going in uncared. There's still a doctor or nurse in that area to help them, and if things change and if they can move out or resources open up, then it once again, it's dynamic, it changes. All right. The immediate category is also somewhat easy to determine. Okay. Easy meaning I clearly see that there is a gunshot wound to the abdomen, needs to go to the OR right away. That's, this does not take a lot of mental Olympics. Okay. So that category, is getting right away care, and they're not going to die, and that category fills up your OR really fast. Okay. And you can probably run, even if you shut down the, everything, you can run here 6 to 8 ORs at full speed, and this is neuro and ortho and general surgery and ENT, and you could probably maintain that for about 36 hours. At that point, you're going to get pretty exhausted. And your staff is going to, you're just not going to be able to maintain it. So this is the category that fills up that 36 hours. Right? All right, this category is really, really hard. Okay? This is the kids that do have something wrong. They are going to need treatment, but it's not immediately life-threatening. So this is the category that needs a CT scan, or they need, splinting of a leg. But they're waiting, and there's not a darn thing that you can do, because everything else is taken up with the immediates. So they go into an area at Children's in the ER, and this category needs help. They need a doctor and a nurse. They need to get to the CT scan. They need someone to put dressings on their legs. They need someone to help, splint and tape up a wound. This is the category where creative staffing happens. Okay? This is where the chaplain's going to get called down to say, hey, put an ACE wrap on that ankle. And it's also the individuals who are going to be challenged with, all right, we're ready in the OR, but we don't have a PACU. It's full. And we got no place to send all the kids in the PACU. The rest of the hospital is full. Now I got a kid that has a broken leg, and I got no way to treat him. Now what? And the answer is, once again, you got to get creative. You got to find a different place in the hospital to do your OR and do your PACU and figure out a way to move the patients. All right. So those are your categories. And as you can imagine, part of what I've been describing is in any given hospital, in any given system, there are specific bottlenecks. These are the points in your system that are going to stop your progress of being able to do anything. Right? So when I review a system, these are the things that I look at. And not just here, in any hospital, there are common themes, okay, that every place has challenges with. Number one, you guys. Guess what? There's only so much you can do. There are only so many ORs that you can run at once. There are only so many PACU beds. And when they're filled, there's not a lot of other options. I will tell you some of the creative flexibility that we can do. Can I do a surgery in the trauma bay? Yeah. Or the ICU? Yeah. Can we convert some NICU beds into ICU and recovery beds? Yeah. Would we ever do that on any imaginable time during regular business hours? No way! Okay, but this is what you're going to have to do to change this bottleneck. Okay? And there is a limit to the flow. Like I said, there's a limit of 6 to 8 ORs at a time. And you can maintain that for 24 to 36 hours. And then you've got a problem. If you cannot move the patients out of the hospital to another facility or something like that. All right. Second big bottleneck that every institution has. If you do that, everybody else following has nothing. There's no replenishment. Well, I shouldn't say no. You can have blood drives that are immediate, and people are amazing in responding to that. You put out a notice to the community saying, we need B positive blood, and it's amazing who shows up. But don't underestimate how quickly the blood bank will go to zero. It happens really fast, which means in your really sick patients, you need to be judicious and give what's needed, but don't get nuts. Usually what's really needed is a stitch and or pressure, and that temporizes things, and that's okay for the time being. All right, the final big bottleneck, the ultimate bottleneck for the whole hospital, the things that end your incident in about 24 to 36 hours, is egress out of the hospital. if you have a hospital like ours that has, what, 180 beds or so, and you have 300 patients that hit the door, do the math. Someone's got to leave the hospital. And you must wrap your mind around unconventional ways to move patients out of the facility. That unconventional means, as I said before, are they walking and eating? Yes, discharge. Would we do that on any other day? No. But on this day, you might. Which patients are capable of being treated at an adult facility? Can I send, all the teenagers to Eden? Really geared towards adults. The pediatric pie piece of that is not really described or robust. And so the new thing that this committee is going to do in the next year is to put the pediatric section within the emergency operations plan that includes evacuation protocols and how hospitals are going to go from hospital to hospital. So hopefully in a year there is a mutual aid system on the pediatric level that is regionally based. So our buddy hospital may be Stanford, and that may be kind of detailed on on a state level of you guys need to coordinate and talk to each other and help each other. That's okay. That's okay. And this is good progress. So hopefully you'll see more of that in about a year or so. There is regional plans just in the Bay Area to look at the PEDS part of disaster management and how the Mohawk FEMA works in the Bay Area. Because once again, it exists. There is a FEMA program, there is a Mohawk and a disaster plan, but the individual hospitals, it's not really together. All right, so enough of that. I'm about out of time, so a few quick things, specific things if you're interested that you can do and get involved with. So number one, there is a plan at each hospital. Okay, there is a disaster map and how it's all going to work. And once again, at this hospital, it is due to be revised in the summer. So sometime in the summer, I'll talk to you again. Get to know what this is. That's maybe one of the best things you can do. All right. Make sure you have your own family and your own house in order, as best as you can. Okay. One of the biggest impediments to being a healthcare provider in a hospital in the midst of one of these things is, where is my family? And are they okay? And there's no way you're going to do your job and help anybody else if your child is in trouble. So have some kind of plan. And this was just an example of that with the Santa Rosa fire. When they evacuated, the hospital in Santa Rosa, this was the comments that they said. The worst thing on their mind was, my own home is burning down. Where's my family? And you gotta, if you're gonna be effective here, you gotta know that your family's safe. All right, there is for FEMA that I was describing, that entire system, there's online training modules that you can take that are free. And once again, hopefully this gets sent out so you can have the website. It doesn't cost anything to do. You go on FEMA, you sign up for these few courses, 100, 200, and 700, and it describes the system, which is, as you can imagine, pretty complicated. You can all do this. Easy. There is a national campaign called Stop the Bleed. This is an effort specifically aimed at people in the community, so teachers and parents, and for school shootings, of how to apply pressure and tourniquets, and it's specific training of going out and doing that. You may see, promotions to get certified in Stop the Bleed. Do that. Okay. This is good cross-training. Okay. This is when I will ask Mary, go down to the ER and put some pressure on that femoral.
I think I'm going to mop the floors.
Less pressure.
And this is what I'm asking Mary to do. And so, it doesn't matter what your role in the hospital is, this becomes valuable. And if you become a trainer and start to train school teachers on how to do tourniquets and dressings, there's a place for that. All right, questions before I'm so sorry, I still ran out of time. I never get finished on time. Anything I can help with? Yes.
Who's the Mohawk contact for this place? Would it be the trauma attending,
Yes, so they will go on ReadyNet for this hospital. And so as soon as the trauma happens, we will go on ReadyNet and update our status. And so we will put on there, we have, availability for 5. And then they know. And and either myself or Stacy Hanover is, available by phone if they want to talk. Other questions?
I
Yes,
was just
ma'am.
curious of those children in Iraq. What did you say, 27? How many of those children survived in that situation?
They all survived to get on the plane, and then they went to Istanbul, and the Turkish government took them from there. So we were able to do a lot of bedside procedures on probably about 10 or 12 of them in the 6 hours that we had them. So I think they all did okay. They were at least stable, thankfully, when they left us. But it was a lot of lessons in that, and not just for me. For the U.S. military learned a lot of lessons with that one. Yes, ma'am.
This is not a question, but if anybody's interested, there's an outstanding book that was written about Hurricane Katrina called 5 Days at Memorial, about 5 years ago. That it's mind-boggling what went wrong, and the people that were making executive decisions at the hospital, what happened to them, and I think a lot of what you said, Tima, came out of the disaster. Just even people working in the hospital not knowing if their families were alive, they couldn't communicate.
Right.
It's very, very, very well written.
There's been a lot of improvements since Katrina. Is it really a well-oiled, smooth, perfect machine? No. It's better. They address a lot of problems, but do not be disillusioned. This would be a 36 hours that is not fun. Any other questions? Yes, ma'am.
So if they had a triage, and if they had like a mass shooting at one of the local schools, would they do the triage at the school and assess them, then send them to the hospitals, or would they just send them right to the hospitals?
No, they would try to secure the school as soon as possible. And often, and it's variable depending on each situation, often that means getting them out of there. So now, schools can, and very often, are set up as a safe place. So, if Red Cross may set up a local school as the meeting place, and the cafeteria maybe where they're housing people that are homeless, and so that's very common. But in a shooting disaster, the security will try to secure it and empty it. Other questions? Yes, ma'am.
I just have a comment. When they have some of the disaster drills, it doesn't involve the regular staff for this year, so I know you have some maybe the upper level that are participating in that, but just the regular day-to-day nurses are not participating in that, so maybe there's some kind of that.
I agree with you. Yeah, I completely agree with you. It's something that needs to be done on every level. So, all right, I've taken up way too much time.